First of all, big congratulations. I was actually in the United States while this was happening. I was in California seeing grandchildren, and I watched the television and saw this absolutely fantastic victory of the Irish team over the All Blacks. It was absolutely brilliant. Nobody expected that might happen. I'm sure they all hoped. And of course, none of us knew, or maybe some of you did, but actually none of us absolutely knew this was going to happen either. And I didn't know what was going to happen when I started out on my surgical career. This is you can see on the extreme right, that's me as a very precocious senior lecturer in the University of Bristol Surgery Department at the age of just on 30. And I didn't know what the future was going to hold either. And since I started out, there have been absolutely astonishing changes in every area of medicine and surgery, of course, particularly in my area, the development of the specialty, tribes growing out of general surgery, and all that means in terms of difficulty and dislocation and so on. The specialist of gastroenterology has rushed on apace, the explosion of new medical therapy now with the biologics and so on. The introduction and the refinement of the ileal pouch has been part of my surgical life, but the outcomes from it are still not predictable, and there's lots and lots of revision work and stuff and trouble as a result of it. So we'll look at some of those issues. This is a very nice self-portrait of a guy named Brian Brooke. Some of you have heard the name Brooke Ileostomy. He was the guy who first came up with the idea of everting the spout of a stoma to make things work well, for the bags to stick on, for the skin to stay in good shape. It was an absolutely brilliant idea, and when you see it, you think, well, why didn't anybody think of that already? Anyway, he was clearly a very good artist, a bit of a polymath, and at the time he was working in Birmingham, he began to see patients with severe ulcerative colitis who could have surgery because he was working with the Dunlop Rubber Company after the end of the Second World War, coming up with ways of managing the waste coming out of an ileostomy. Up until then it was pretty difficult to manage, skin got burnt and so on. And he founded something called the Ileostomy Association, which is a patient help group. And there is a Dublin Irish branch of it. I know this because I'm the current president of it in the UK. And earlier this year, we celebrated the 60th anniversary of the Ileostomy Association. And 5 ladies in their 90s were all there who had all had colectomy in the very, very early days of surgery for this condition. And it was very, very compelling hearing their personal stories. Absolutely amazing. You would think that these people had AIDS or some terrible contagious disease. At the age of 18 or 19, they were skinny as a rake because medical therapy wasn't very good, nutrition was poor. They needed great courage to have surgery, but often it was life-saving. There was no alternative. And when they had an ileostomy, you couldn't go into formal education, you couldn't get a job, you were confined to your house, and it was just like being a leper. Absolutely extraordinary. And how that has completely changed in those 60 years is both astounding and absolutely wonderful, because these are all young patients who have a life ahead of them, and it's great to see the way it's changed. Now, of course, after the Brooke ileostomy came the ileoanal pouch, and I'm not going to talk about the history of it very much, but 1978 first reported in the history of the universe. It's not very long. In the history of abdominal surgery, it's not long at all. And clearly it's had the possibility of completely dramatically changing people's lives so they don't have to have an ileostomy anymore. So part of my personal journey was that I was a registrar at St Mark's Hospital, which then was the only specialist hospital dealing with colorectal problems in the UK. That's all completely changed, of course. Our place in Oxford is trying to do a good job, Leeds doing a good job, and so on and so on. And some of the early patients having this pouch operation were actually on the wards while I was a registrar there. And if I told you that one of them had been on the ward for 10 or 11 months. You might not be surprised because it was the early days of developing a brand new operation. It was tough. There were loads of complications. We didn't really know how to manage them very well, and it was a massive uphill struggle. But here we are. This is a huge estimation. We reckon there probably are something like 75,000 people walking around with an ileoanal pouch now, around the world, globally, because obviously surgery and medicine is now a global issue. And of course, even if you're not actually in the business, you might meet one day, as it were, a patient with one who has something else the matter with them. So it's kind of helpful to know a bit about it. In 1986, I moved to Oxford, and on the staff just retiring was this famous physician named Sidney Truelove. He had come up with the famous Truelove criteria for judging how bad an attack of colitis was. He was the guy who said, if by day 5, gastroenterologist, the patient isn't getting better, you'd better get a surgeon to see them, otherwise they might die. He was the guy who really focused attention on the relationship between medicine and surgery to make sure that that worked well. And I love this quotation of his. You know, going to a place like Oxford, you've got to have a Nobel Prize before anybody takes any notice of you. And can you really have such a thing as a surgeon scholar? And Sidney Truelove put it well. The trouble with surgery is that it hardens the feet and softens the brain. You know, you're standing there for hours and hours and hours in theatre, and your feet get hard and your brain softens up because you haven't been intellectually challenged too much, at least during much of the surgery perhaps. He didn't mean that in an unkind way. He was actually very, very pro-surgery. And his, if you like, philosophy was that surgeons and physicians should work together. So it was a good start, and it was a great place to begin to work on this problem. So what I thought I knew then, I thought I could do pouch surgery, and I knew exactly what all the problems were. I thought that the pouch was the perfect solution to the ulcerative colitis problem. I thought I was very, very good at it. When you're young, you're arrogant. I thought I was better than my colleagues at it too. I could take very big risks on behalf of other people without thinking twice about it. And of course, I thought I'd live forever. Well, in a generation, and this is old Bruce Forsyth's generation game picture, in a generation we have seen the creation of pouch surgery, its technical refinement, massive advances in medical therapy. We have seen people doing one or two. We've seen many complications, and now we are into the age of redo surgery. And this is an area like many others where there can be surgical ecstasy. The guy in white is a patient of mine who almost looks as though he's having a pouch inspection whilst doing a skydive. But he is completely well and doesn't have any, if you like, functional problems related to his surgical reconstruction. There's another patient of mine who we thought, as far as we could possibly tell with our hands on our hearts, definitely had, without any shadow of a doubt, ulcerative colitis. It turns out that wasn't the case. Within 8 weeks of closing the ileostomy with this pouch anal anastomosis, the perineum was like a watering can. We'd done our absolutely best to be sure, and hey, this is what you get. It was an absolute nightmare, and you can see eventually that wasn't going to work out, and that had to be removed. So I was part of putting together a UK-wide pouch registry, and the advantage of this is, of course, you get enormous numbers, and you can make comparisons and talk about things. And here is anonymized hospital data, right from the top St. Mark's, then us, right down to hospitals doing maybe one pouch. Interesting. During this time as well, the style of pouch you can see there has changed in the red dots. The rise of the J pouch, a way of constructing the reservoir, compared with the W pouch, which has kind of gone out of fashion. A simplification of the surgical technique. We don't need to kind of go into the detail. And here Now the rise of the biologics, these monoclonal antibodies which can switch off inflammation dramatically and probably do have a slightly deleterious effect on surgical outcomes, but much less than we were worried about to start with. Nearly 2,500 pouches on the registry. It's being revised at the moment. We're probably going to have 5,000 or 6,000 on it when it's re-put together. You can see there we've got data in the left-hand column for primary pouches and in the right-hand column for revisions, which I'll talk a little bit about. You can see this is a group of young people having major surgery between the age of 15 and 40. And they've got life ahead of them, and it's got to go well, and you've got to do a good job, and you've got to make sure it works out all right. But clearly it doesn't always, because, in the second column, you can see there are a number of pouch revisions, and they're slightly older, maybe 10 years later than the group of patients having the primary operation, and redos are around 7% of the total. And in my own practice, the numbers of reoperations or redos increased from when I first started up to 20%. So 1 in 5 of the cases we're doing now are redos. Now, pouch surgery is not unlike any other surgery. You have the classic complications, bleeding and infarction of the parts you're moving around, sometimes peritonitis or a leak. And then you have some specific later complications you can see there on the right-hand side. It is one of the biggest abdominal operations we do, and it is prone to complications. And as I say, it's in this young group of patients who we want to try and get a good job for. And you can see there, around 25% of all of the patients are having a significant complication, and the biggest of those is around infection and sepsis. So many people have used this sky team analogy, the whole idea of trying to make things as good as you can by making tiny incremental changes to make things as good as you can. And I guess that's gradually what's been happening over time with pouch surgery. But there's still a way to go. The big problem is the leak. And the big problem about the leak is not just that it happens, but in many patients it happens without us realizing it. I think a number of patients who have poor function later on have had a tiny leak which was never ever discovered in the first place. And the leaks and sepsis can happen from all these places: the top of the pouch, the join, the side of the pouch, you name it. It can happen anywhere, and it is a major cause of pouch failure. If you have sepsis, the pouch goes down, you have worse incontinence, and you have a lower quality of life score. Pouch failure is defined as a pouch that's been defunctioned for 6 months or more, and the most common causes of temporary or permanent failure in my book then are actual or more commonly occult anastomotic leakage, leaving too long a remnant above the anal canal of inflammation which can become stenosed. Inadvertently, a pouch can be twisted down 180 degrees. I've even seen 360 degrees. Omission of the diverting ileostomy when it was prudent. Using new technology before it's tried and tested. And like the case I showed you right at the beginning, maybe Crohn's disease in evolution. For revisional pouch surgery, there are 2 peaks. Obviously immediately around the time of the operation and then much later. And some of these are these occult sepsis patients. So during my, if you like, surgical lifetime, I've been part of creation of the primary pouches, and now I'm part of helping, if you like, the revision surgery. And this is a nice slide showing overall failure rates of, at 10 years, around 10%. But it probably does go up to beyond that. And you could probably say 15% at 15 years. And part of my job now has been the sort of salvage side of surgery. And like any of the areas that we manage, making an early diagnosis and getting on top of it really quickly is absolutely essential, and you can do it in these ways. We would have a very low threshold for getting on top of it, because if you don't, it can be a nightmare. And the early abscess or anastomotic dehiscence must be managed very, very aggressively. Drain in abscess, resuture, or advance a small dehiscence. A big dehiscence, take the whole thing down, place the pouch in the wound as a mucus fistula, or if it's a tiny leak, wait, do a pouchogram and reconsider reoperation in due course. Basically the message is, 1, identify it, 2, manage it aggressively, and this is one of the interesting novel ways in which these leaks are being managed, both in cancer surgery and here in pouch surgery. A suction device on the end of a sponge so that the cavity is pulled in, whereas in the bony cage of the pelvis it can't contract down and heal up. And there's some evidence, which I won't give you today, that this is an effective way of managing it. So is all the salvage business worthwhile? Probably the most successful indications for reconstruction of these operations are the mechanical ones. A small pouch, a long blind limb, a twisted pouch, which I've talked about, pouch prolapse, or an anastomotic stricture. All these things are good things to be able to manage. It's much more difficult if you have sepsis as the cause of failure. These are difficult problems to manage, and as you can see here in this data from the Cleveland Clinic, they have made new pouches. They've been able to refurbish some of the old pouches. They have a 20% failure rate, which is probably better than most of us can possibly achieve. Here's some figures from Paris Tekis, and you can see the one with the star on the right is the one where the patients either have a mechanical or no septic indication for revision. You've got the best chance of doing something if it's a mechanical cause. You've got the worst chance of doing something if it is a septic cause. So the message comes over, let's try and try and try not to have a leak, even an occult one. And out of these redos, you can see there in our practice, we've managed to close stomas, but this is a really, really tough area, and you have to choose the patients well. It's difficult surgery. You have to do it open. You have to put in ureteric stents because the ureters get medialized. You have to excise a big abscess cavity. You might have to repair or even completely augment or replace the pouch. You have to do a mucosectomy, a hand-sewn ileoanal anastomosis with a Lone Star retractor, and you have to defunction. And of course, because it's a big deal, there are going to be more complications. And here's our data from the UK registry. Now complication rate is getting up towards 35% or more, and pelvic sepsis again is a complication of it, usually in the patients who've already had the sepsis in the first place. Failure is 3 times worse after a redo than the first time round. And this is an important message, because all of us need to, whatever we do, try and get the thing we're doing right first time. And this area, more than any, is strewn with patients who have had a so-so operation, it's not right first time, and then they have a lifetime of misery whilst it's sorted out. This is quite a nice algorithm for managing the various problems with ileoanal pouches. You look at the top. On the left-hand side, where the rectum has been left too long, where the efferent limb from the pouch is too long, where the pouch is too small, where it's twisted, where there's Crohn's disease, there is a way of managing it, and patients who are suitable should certainly be offered it. But of course, these are patients who've come through that journey. They've had the endileostomy. They've gone through having a pouch. They've experienced what it's like not to have an ileostomy bag, and they say, what else is there? Well, You can excise the pouch. You can convert to a continent ileostomy. Pouch excision is tough, as we've said. You have to really set it up very well. It can be a very, very difficult, long, complicated, tough operation. You have to take the anus out, otherwise healing is delayed, and you have to consider whether or not you really need to do it. And one of the options is what we now call indefinite diversion. You don't necessarily need to take it out, you can just leave it there. And these are a couple of papers showing that indefinite diversion, provided the patient doesn't have any symptoms from their pouch, is a perfectly reasonable option. You can convert the failed pouch to a continent ileostomy, which we've done 4 or 5 times in Oxford. We're one of only 2 places in the UK still doing cock pouches. But again, it's tough, and the patients have already, by the time they come to revision surgery, had a lifetime of reoperations, and they're now taking on a continent ileostomy with a big, big issue related to pouch valve revision and so on. So they have to be really, really up for it and carefully considered. So if there is a pouch failure, what are the options? To summarize, there can be a local repair or there can be an abdominal repair. You can repair the old pouch, make a new one, convert to a cock pouch, leave in place with indefinite diversion. 70% success rate overall is the message for revision surgery. So, when I set out, I thought I knew everything and could do everything on my own. And what I now know is that that's obviously completely impossible. You have to be part of a team, which includes physicians, pathologists, radiologists, specialist nurses to share the care. And it's interesting now in Oxford, if a patient after an acute colectomy has a major complication, the gastroenterologists see that as part of their responsibility too. Did they get the patient to you in time for you to do a good operation without complications? So it's not just, if you like, the surgeon's fault, it is the team's fault if anything has gone wrong. Most importantly, these are a young, vulnerable group of patients who have had a real bad hand of cards. And if you then subject them to surgery, which is less than the very, very best you can do, that's no good. They are very easily victims, but they're also a constant source of inspiration. I've said halfway through, getting it right first time is absolutely what this is all about. Spend lots of time setting it up. There's no excuse. Quicker intervention for leakage. There have been various, if you like, fashions during the course of this surgery and other forms of intestinal surgery around the use of a stoma. Surgeons have felt, well, I'm so good, we don't need to defunction this, and anyway, stoma's horrible, and we'd like to save the patient it. Well, I can tell you, I've been in and out of those iterations, and I now use stomas liberally to make surgery safe. This operation of pouch surgery is a kind of lifestyle operation. You want a nice, soft, squidgy pouch for it to work well. You don't want a thick, fibrous pelvis from sepsis. Use a stoma to mitigate the effects of leakage. Again, as I've said, often occult and, if you like, below the radar. Absolutely obsessional attention to detail. These are not cases to do at the end of a list or to do when you're about to leave the country or when you're about to dash off to a committee meeting. They absolutely have to be a priority. I think there's another message too. I think early on you feel very proud of your surgery, and even if it's gone wrong, it's difficult to raise the white flag and say this is the end, this is no good, we should stop. I put here, don't persist unreasonably. In other words, if the patient's having a really tough time and they've gone round the roundabout 4 or 5 times of revision and redo surgery, I think have that difficult conversation about saying it's time to stop. It's a difficult one to get to for many people. I think the development of the IBD MDT has been very good. Of course, we've got here Venus on the left, the physician, and Mars on the right. He's absolutely exhausted from a major long pouch operation, as you can see. But again, as I say, sharing the care with a whole group of people is absolutely what it's all about now. You protect yourself. When that patient goes down in a spectacular fashion, it's the team's responsibility, not yours. And especially with the redo procedures, you need a group of people to help you decide, is this the right patient to do it on for the right reasons, and are we going to come up with the right solution? So joint responsibility. Again, what I know now, focus responsibly on technical advances. In other words, let the technical advance mature enough to apply it in this special group of young patients who can't have anything left to chance. Better leadership over super specialization. I think this is a very difficult area, and if surgeons are trained to a high standard and they have good hands, yeah, everybody should do everything, but this is an area where there needs to be super specialization. I'm still seeing things I don't understand. We did a pouch about a year ago, and it's a big chunky guy, and the operation seemed to go okay, but he has the most terrible intolerable diarrhea from his pouch. I mean, not just going 3 or 4 times a day, he's going 20 times a day. We've reviewed the pathology, we have gone over him with a fine-tooth comb with the gastroenterologists. We just don't understand why it's happened. There doesn't seem to be any obvious cause. There's no occult sepsis. So I'm still seeing things I don't understand. I thought I knew everything. I don't know everything. And I think some of the things I've seen and some of the patients I've seen and some of the way they've managed their complications and problems has taught me enormous humility. And of course, I'm not going to live forever. What will happen to pouch surgery over the next decade? Well, after all that's happened in the last few weeks in international history, who knows? I mean, some say this surgery in 10 years will be obsolete because medicine will be so good. I think it's unlikely. Maybe the numbers will go down. We don't know. Or medical therapy could improve such that if you leave a bit behind, say you leave the rectum behind, you join the ileum to it, medical therapy will be so good that we don't need to chop all of the rectum out, and that removes a whole series of problems, and you do an ileorectal anastomosis. It has been suggested, we don't know yet. Obviously, if the rectum gets to the point where it's a stiff, rigid bag and it can't expand and contract like a nice floppy, if you like, bladder, then it's not going to work out, but we'll see. Colitis will be better managed, but patients will still need proctocolectomy. And again, this is a very, very important area of physicians and surgeons working together so that the patients aren't managed medically for too long. But we have to hold our hands up as surgeons and say we don't have a perfect solution. We don't have a perfect solution functionally for this problem, and we can't always get it right when we do it. You probably can say without any shadow of doubt that pouch surgery will become more minimalist. Certainly the abdominal part is all being done laparoscopically all the time. I haven't talked about that today because that's a slightly separate issue. And the bottom-up rectal dissection will be used more and more, and we'll go back to using a single stapled pouch anal anastomosis, and perhaps that will reduce the numbers of those occult sepsis cases that we don't recognize until much later on. And what's also for sure is that there will continue to be a backlog of old pouches coming back for revisional surgery. And during my practicing lifetime, I've been in on the beginning, and now I've seen the development of a whole, if you like, now section of patients needing revisional surgery. And it's interesting to have seen that during that whole time. So the whole problem, of course, is that none of us can predict the future anymore. But it's interesting looking back to see how much has changed and how much I've had to rely more and more on a group of colleagues rather than just myself to get it right. So thank you very much for your attention. I'm very pleased to answer any questions. Thank you.